Hello, everyone. I'll start by welcoming you as we have more participants joining us. Hope wherever you are that your day is going well. My name is Fiona Mazurenko, and I'm the Director of Global Alumni Relations at the University of Texas at Austin, and I'm thrilled to join you today for our conversation on the Texas Global Dialogues on global health, breakthroughs, challenges, and a way forward for UT Austin. We have a great conversation in store for you today. Before we get started, I want to point out that this event will be live interpreted in Spanish. So if you would like to listen to our speakers in Spanish, please use the menu at the bottom to click on interpretation and select Spanish. Just a few more guidelines. Please note that all of our attendees are muted with their videos turned off during our webinar. Only our speakers will have their videos and audios turned on. But we still encourage you and want you to interact with one another using the chat feature. Just make sure to select all panelists and attendees. If you've got questions, please use the Q&A feature and that will reach the panelists, and we'll have time to answer questions after the discussion. We'll also be conducting a number of polls and encourage you to share your response. And should you require any assistance during the webinar, please also use the Q&A feature to communicate with the hosts, and we'll be happy to assist you. And now, looks like we've got a number of participants in the room. I would be happy to introduce Dr. Sonia Feigenbaum, the Senior Vice Provost for Global Engagement and Chief International Officer at the University of Texas at Austin. She will serve as the moderator for today's event and provide a welcome now. Dr. Feigenbaum.
Thank you so much, Fiona. Good morning, good afternoon, good evening from wherever you're joining us. We're so delighted to have you with us today. I know this is truly a global event based on the registrations we received for today's dialogue, and I'm delighted to welcome you from all corners of the world. So please share in the chat room where you are now, and we'll make sure to connect later, and we'll make sure to spotlight you depending on which countries you're from. Oh, I see that's one's from sunny London. So I'm Dr. Sonia Feigenbaum, and I'm the Senior Vice Provost for Global Engagement and the Chief International Officer for the University of Texas at Austin. I'm really delighted that you're joining us for this Texas Global Dialogue on a really timely topic, global health, challenges, breakthroughs, and a way forward for UT Austin. This is really our fourth Texas Global Dialogues, which we started during the pandemic, sadly, that we have conducted virtually. And we're so pleased to co-host this event with the Texas X's in every Texas Global Dialogues with the Texas X's during International Week, which we also call IEW. In a nutshell, IEW is a joint initiative of the U.S. Department of State and the U.S. Department of Education that promotes and celebrates the benefits of international education and exchange worldwide. And so we're joined with institutions around the world, as well as organizations that are focused on internationalization. And we're all creating a set of events during this week that showcases the work that's taking place. So for UT Austin, we have over 80 events. You can access them. Some of them are in person, some of them are virtual, and we'll be happy to share this information with you in the chat room. But all this by way of saying that it's a really propitious moment to be talking about global health. You may know that Texas Global advances UT Austin's academic mission. We lead, we support, and we coordinate the university's international engagement efforts. We create and foster partnerships that are strategic on campus and abroad, and we welcome the brightest and most impressive international students. Many of you were those students, and scholars to campus, and we offer opportunities for students and faculty to engage with peers and institutions around the world. As you know, the University of Texas at Austin is committed to connecting more closely with our global alumni and Longhorn community. In my international travels, I have had the pleasure to meet with many of you, and I've listened to your clear message. You are seeking more engagement with the university's academic mission. And so prior, in 2020, prior to us coming together, we launched the Texas Global Dialogues, which brings us together today to showcase UT's intellectual enterprise and engage our alumni abroad. Our conversations have led to tangible outcomes. We have established a new global alumni relations team at the university led by Fiona Mazurenko, whom we've just met a few minutes ago. And she and her colleagues are collaborating closely with the Texas X's, with colleges, schools, and organizations across UT to increase opportunities for faculty and student engagement with alumni abroad. And I would be remiss not to mention our colleague Thuy Nguyen, who here is behind the scenes as a global strategies officer, who's been instrumental in having us take these global events, these Texas Global Dialogues forward. So while today's dialogue is virtual, we're excited to expand our work in this area, and we look forward to continuing these events in hybrid format in the future. And by hybrid, I mean that the vision is for us to be in one of the locations where you are now, to be meeting with you and to hold an event in person, but also have it in virtual format at the same time. So we will continue to bring together UT alumni to engage in meaningful conversations with the university. We're looking forward to an exciting lineup for 2022. Our events are going to vary in format. We don't really want to be formulaic. Some will feature a panel of UT faculty and alumni leaders for an in-depth discussion on the topic of global interest, and others will include invited guests whose voices are of interest and coincide with UT's strategic research initiatives and endeavors. And we will also look forward to including other campus leaders who will share their thoughts on the work that's taking place on our campus. We're so thrilled to collaborate with the Texas X's on these events, and in this case with Dell Medical School of Medicine, and our global alumni outreach. Texas X's has numerous chapters and networks in cities and countries around the world, and they continue to grow. We encourage you to learn more about the Texas X's chapters and programs near you. With that, I'd like to welcome Chuck Harris, the Executive Director of the Texas X's, to give a few remarks. Thank you.
Thank you, Sonia. What a great opening. We're just thrilled to partner with Texas Global. One of the pillars of the Texas X's is I like to think of ourselves as a convener of alumni around the world. And it's so great to have content and programming for those alumni that generally don't get to come in person to football games and the events that we have here. So it's great to be able to do these virtually. As Sonia said, I look forward to getting back out on the road and doing some of these in a hybrid format, but we're excited. This is just the beginning. I know we've been about a year since the last one, but we're still experimenting and building out programming. So more to come, and our partnership is strong and looking for ways to be creative. So anyway, welcome everybody. It's a pleasure to be here with Texas Global and Sonia, the partnership we have. We absolutely appreciate that. So enjoy the day, and I will turn it over to the next person in line here.
Thank you, Chuck. Thank you so much. Well, as you know, the COVID-19 pandemic has impacted all of our lives in myriad ways, and it has created a lot of grief, but also a lot of hope. And it's reminded us of our interconnectedness. And today our panel is going to discuss global health policies, trends, challenges, and opportunities. We'll also share with you exciting developments in UT's Global Health Program, a collaboration between Texas Global and the Dell Medical School. So without further ado, I'd like to introduce you to our panelists who will tell us about their work to set the context for today's conversation. First, we have Dr. Peter Cowley. He is a UT alumnus who's now leading health policy and financing in the Western Pacific region for the World Health Organization. We're so delighted to have you here with us today, Dr. Cowley. And we have also Dr. Tim Mercer, who will also talk about his work. He's the director of the Global Health Program at UT Austin, and he's an assistant professor in the Dell Medical School in the departments of population health and internal medicine. Dr. Cowley.
Thank you very much, Sonia. And as I mentioned, my name is Peter Cowley, and I'm a proud alumnus of the University of Texas. I actually grew up in Austin, one of the rare people that did, and even claimed to continue to be a University of Texas football supporter after this year's season. So I'm a rare breed, I guess. For me, in professional development, I have worked and lived in over almost 10 countries in Barbados, as well as Republic of Georgia, Uganda, Cambodia, the Philippines, where I just moved from over the weekend. And I've joined the World Health Organization headquarters as their senior finance and service delivery expert. My background is I'm a physician, trained at the Baylor College of Medicine, and did my residency at Johns Hopkins, but I have a specialty in health economics. So I assist countries in some of their financing challenges in terms of delivering healthcare, in particular around COVID-19. Over.
Thank you, Peter. Tim.
Hi, good morning or afternoon, evening, everyone. Tim Mercer. I'm the chief of the Division of Global Health and lead Dell Med's Global Health Program, as Sonia said, in partnership with Texas Global. I am not a local Austinite, a transplant like most of us these days, but have fast become a loyal Longhorn and proud to be part of the UT family and the Dell Medical School, the new medical school here. And we're so thrilled to be part of the larger UT Austin community. I'm actually originally Canadian, but grew up in rural Indiana and did my undergraduate and medical school there at Butler and Indiana University, respectively. Did additional training in public health at the Yale School of Public Health, and then my residency training in internal medicine and pediatrics at Duke. Actually all throughout my training, I worked with a program in Kenya called AMPATH, the academic model providing access to healthcare, which is a large academic global health partnership between a consortium of 14 North American and 1 European academic medical centers, and Moi University, which is a medical school in Western Kenya, and the Kenyan Ministry of Health. And so I've spent my whole career in global health sort of vis-a-vis the academic sector, working around healthcare delivery, population health interventions, research, and training. Following my training, I actually lived full-time in Kenya for a couple of years as a faculty member at Indiana University and with a joint position at Moi University there in Kenya, on the ground, providing care and helping build the program, and then have been here in Austin for the last 4.5 years, leading our global health partnership to engage faculty and students at the Dell Medical School and across the university in global health work, specifically with this partnership in Kenya. And then we're building a new program in partnership with colleagues in Mexico. So more on that later, but thrilled to be here and to be part of this conversation at such an important time in world history.
Thank you both. Before we start our conversation, let's take a minute to conduct a couple of polls. We're really interested in knowing where you all are coming from. Our first poll is related to geography. So where is everyone turning in from? And what part of the world are you currently located? We're really interested in finding that out. And Fiona will share our results.
Give it a few more seconds. I think a couple more answers are coming in. Looks like we've got spread from Asia, Europe, large concentration in North America, and some tuning in from South America as well.
Wonderful. Thank you. That will certainly inform our conversation today. Now that we know which world regions are represented among our audience, we would like to know what you think are the most pressing global health challenges. And if you don't see it in the list of choices, please add it in the chat. We have infectious diseases, infant and maternal mortality, climate change, pollution, and poverty.
Give you a few more seconds to get your answers in. And then share the results.
I see that infectious diseases and climate change are poverty at the top. Okay. Finally, we are curious about one more thing. Which of these should be considered when we discuss global health? I think there's going to be quite a bit of conversation about how one defines global health. So please check all that you think applies. We know that the list is not comprehensive, but we're just curious. We have the treatment of disease, public health policies, effects of colonialism, energy crises, environmental and biodiversity conservation, and international aid.
Good answer. Still coming in. About 50% of participants have put in their choices.
I think while we're waiting for the responses, one of the things that is going to be really important for today's conversation is how one defines global health. What do we think of when we hear global health? As medical professionals, both Peter and Tim have extensive experience working all over the world, as you heard, on global health initiatives. And for the benefit of our conversation and in line with the results that we're gathering right now, I'd love to know from both of you how we can define global health, at least for today's conversation, and generally, what are your thoughts, Peter and Tim?
Yeah, great question, Sonia. And this is actually how I start my class. I teach to the first year medical students. We spend the entire first class session just defining what is global health. And mind you, this is with a group of students here at the Dell Medical School, many of whom have rival my experience, I might say, in terms of what they've done before coming to medical school, living abroad, being in the Peace Corps, working. We have a pretty amazing student population. But even still, with these young experts in the room, we have a rich discussion. There is a quote unquote definition of global health in the literature and published in the Lancet about 10 years ago. And as many academic definitions, it packs as many concepts as possible into as short and succinct a sentence as you can, but it includes element equity is right up there at the top with a focus on health equity. It evokes concepts of, being concerned with transnational determinants, solutions, things that move across borders, like COVID, for example, and now people. It's clearly interdisciplinary, requiring more than just medicine or health folks. And I think that'll be a theme we talk about throughout the morning. It's individual clinical level, but it's also clearly population level. And it includes research, study, and practice. So those are some of the key concepts. It's clearly, a broad definition. And another thing we discussed, there was a paper study out of Germany, I believe, that asked a bunch of global health leaders basically how they define it. And they come up with some beautiful figures. And the takeaway is it's kind of everything. And if you look in there, there's climate change and economics and politics and medicine and sociology and anthropology and all of these topics. So I think global health is clearly anti-reductionist and casts a wide net in terms of trying to improve health and specifically health equity for all. So I'll turn it over to Peter to add to that.
Thank you, Tim. And once again, I'd like to thank the organizers of this webinar for such a smooth production and for the invitation. You know, for me, yeah, a lot of it's around poverty. You know, global health, and you know, some institutions such as the World Bank and some of the regional development banks, such as Asian Development Bank, Inter-American Development Bank, IMF, the International Monetary Fund, they tend to look at the relationship between poverty and health. And you know, oftentimes there's been numerous studies looking at a person's socioeconomic status and their health outcomes. There were some classic studies done in the United Kingdom some 50, 60 years ago, which actually categorized groups of individuals by education and categorized them by their wealth, essentially, and their buying power. And it looked at what their health outcomes were. And again, this was in a system that was pre-National Health Service. And yeah, there was, you could see it, you know, cardiovascular mortality in general, in infants, in adolescents, as well, in particular in adults, shot up in the lesser socioeconomic developed groups. We see this a lot in global health and the relationship between poverty and health outcomes. And increasingly, there's getting to be some movement in trying to alleviate poverty through expansion of equitable health programs. And the theory is, which is increasingly becoming the reality, is that once you get people in better health, in particular nutrition programs, in terms of early childhood development, they have better education outcomes, they have better opportunities in the job market, and there's a general economic growth associated with investments in health. And some have said that this economic growth is on the factor of, I've heard, a return on investment of, you know, above 5 to 1. And you can make the case that this is in many different arenas, but for me and for many others, global health is increasingly becoming more international, both in exposure, as well as we've seen from the COVID-19 epidemic in terms of infectious diseases. And also it's becoming increasingly important in terms of economic growth, as the world, as we've seen, is interconnected, not only in terms of disease patterns, but also in terms of economies. We've seen huge reductions in certain countries' economies. Every country on the globe has suffered a hit because of COVID-19. And this is only a symptom of what we have always believed in, and that is that poor health outcomes among any person in the global population affects not only that person and their family, but it also affects the economy in general. And that economy is not just the national economy or subnational economy, it's the international economy. So for me, it's that relationship is of key importance, is that it's more than traditional thinking of it's global health is about disease or about health itself. It's about the relationship between health and in particular economies. Over.
Thank you. You know, I think this is your perspectives are incredibly interesting, because one of the perspectives, and I would say Tim's perspective, really focuses on sort of the academic approach to global health. He spoke of the non-reductionist approach, bringing in a variety of academic disciplines to inform the work that's taking place in global health. While you, Peter, are really focusing on something that's very much at hand, aligned with the idea of economics and the idea of poverty reduction and so forth. So that, I think, is bringing two views that are not mutually exclusive at all, but that can be expansive. And I'm really curious, in your role at the World Health Organization, Peter, how you handle policymaking in terms of ethics, for example. You know, what is the role of ethics in global health when you're thinking about reduction of poverty, when you're thinking about distribution of vaccines or creation of vaccines, or or the production of vaccines in a variety of countries. Can you tell us a little bit about, you are informed, your perspective is informed on the idea of reducing poverty, but there are all sorts of ethical components, and we're really interested in the policymaking angle of that. Could you share that with us?
That's a great question, and I think that an answer is one given from what I heard from some Ministry of Finance discussions. I'm in an odd position. I deal more with ministries of finance than I do with ministries of health at this point. And part of that reason is ministries of finance, they're the ones that fund ministries of health. They're the ones that fund health programs in most countries. The United States is different, as are a few other countries where it's private sector delivered and it's a private insurance market. But in other countries, it is predominantly from taxes, and yet that's how healthcare is being provided. And when you look at that and you speak to someone in health, it's always chronically underfunded. It's just, it's a standard response. But when you speak to Ministry of Finance, they are not so certain that it's underfunded, because there's no marker to say that it should be X or Y amount. You start to look at different kinds of arguments rather than going to ministries of finance. And this is something I help ministries of health with on a daily basis, is to create different arguments and to create different scenarios. And one of these scenarios, which is of crucial importance, is that if you increase the budget for, say, healthcare, you have to do it in a way which is equitable. And the reason why it's equitable is not necessarily on ethical grounds, and it may not be on grounds of this is something that's part of a national strategy. It's on economic grounds. You start to see that there's, by, for example, vaccinating, having everyone having equal access to the vaccine. There have been some recent studies that show that the return to the workplace and the return to pre-COVID-19 economic activity, it can only happen when everybody gets the vaccine. It isn't when a certain portion. You need shop owners to man the shops. You need people to buy at the shops. And that in itself is a reason enough, much less the reasons associated with stopping an epidemic in terms of dynamic transmission. That's one aspect. You need to vaccinate as many as possible to reduce the transmission from a public health and epidemiological point of view. But there's an economic argument as well. And that economic argument about taking an equitable approach. And that approach is that everyone benefits from an increased economic recovery if everyone gets access to the vaccine. The same type of argument can be used for healthcare in general. Again, studies have shown over and over again the loss of productivity and the loss of income to families and to individuals associated with lack of access to healthcare. There's literature is well established in this. So something that I do on a daily basis is don't just mention it in terms of equity for equity's sake, but mention it in terms of equity because it's good for the economy. And when it's good for the economy, it's good for the government revenue base. And when the government revenue base goes up, that in turn can increase the funding envelope for social programs. So it's a virtuous cycle that is positively reinforced, as opposed to poor health outcomes, which often are associated with inequitable distribution of healthcare. And that the cycle continues to be negative as opposed to a positive, more economic growth scenario that's associated with equitable distribution of not only vaccine, but in healthcare more generally. I just would like to add something, and I thought this was fascinating, and that I had a discussion with the Minister of Finance, and it was speaking about how the world is connected. And they were very concerned in Vietnam. They were very concerned about not only their vaccination rates or their stopping COVID-19, What they were very much concerned with was a global approach. For example, they were concerned about Korea and Japan and other countries in the region returning to business as usual. Why? Because they purchased Vietnamese-made televisions. So this is, again, the connectivity of global health and the economy. And the global economy is that the ministries of health and finance in Vietnam are concerned about other countries' recovery, not just their own, because the world is interdependent economically, and they sell less TVs and they make less TVs, and they have less people employed in the TV making sector if other countries have not recovered to their purchasing power. And again, this is an argument that I think that we could benefit from in terms of global health, is closer ties to economic growth. Over.
Thank you. Well, thinking of interdependence, which is economic, I think one of the questions that has arisen has been the politicization of how to respond to the pandemic, the messaging around the pandemic, and we're going to put a few polls up because we're really interested in how people perceive the pandemic, especially as it relates, or how people perceive global health and infectious diseases as it pertains to diseases that have been either eradicated or that we're looking to eradicate. So there's going to be a poll on that, but there's also an interesting thought to be given, which is, we talk about the number of people who have died as a result of COVID-19. We'll be curious as to what the audience thinks in terms of the numbers of individuals that have died because of COVID-19, as well as Ebola. And what really comes up here is when you're talking about the connection between the economy and eradicating or bringing the vaccine to every individual so that the economy can start up or can improve over time, that unfortunately hasn't been looked at, or every country has not espoused the use of the vaccines similarly. And so I'm really curious, now that we're trying to end the pandemic, if you can help us understand how the response has varied from country to country, and how politics, the private sector, and health systems have impacted that response. So what has the response of the World Health Organization been? But also from an academic perspective, we're really proud to have had a hand in the development of the vaccine, and Tim can speak to that as well. So I'm curious if both of you could speak to that.
I can start, but I think Peter's probably really the expert here on this topic. But I think, yes, UT had, was involved in sort of the pipeline and early science and generation of these vaccines, and obviously America as a manufacturer and distributor. But I just think we have largely retreated within ourselves, and I say that to not just America has done that, most countries, and despite, it's been this great, I think, irony and paradox, despite this global pandemic that has demonstrated, I think, more clearly than anything ever before, as Peter was saying, how interconnected, how interdependent we are. It's so obvious that the coronavirus does not care about the US-Mexico border or any other artificial country border, that we have, as a global community, largely, I think, retreated into fairly nationalistic strategies and policy making, and that includes vaccine distribution and allocation. And here we are, going on 2 years later, coming down the slope of the last variant, and I'm not sure there's not going to be another variant and surge ahead of us because of that strategy. As the Delta variant was surging in India, and we were sort of masks off, reopening last however many months ago that was, we knew it was coming, yet we weren't talking about vaccinating people in India, which if we were going by sort of the science and epidemiology, maybe we should have been having those discussions at a real, practical level. We were sort of debating, parochial, local, state policies here. So I just think we have lacked this broader worldview and really bringing that into practice. And I get it; it's hard, and that is at odds with sort of how we tend to do business in politics and the global economy. But man, we've got to.
If I may, thank you, Tim. Some of the response has been, Tim had alluded to that, is, the country got hit by the variant at what time? It came down to a lot of that. Because the variant, particularly Delta, came to Asia a little later, and it started in the UK, apparently. Not started, but it started to be recognized in the UK because of the surveillance system fairly early on. And to answer your question more specifically about how countries have mounted a response and what do we know from the evidence, and that is, one is there's some cultural differences. There's some cultural differences as well as some historical differences. For instance, in East Asia, the use of mask wearing, the use of quarantine, and contact tracing was fairly well established. And this was as a result of the avian flu epidemic, otherwise known as bird flu. So from 10, 15 years ago, they had practice. So there was a certain amount of being ready. And if you look at the incidence rates of COVID-19 in many countries in East Asia, they're a fraction of what they are in Europe as well as the Americas. And the second is related to what is the health system that was in place or is in place. And that is where the evidence gets to be a bit more confusing. For instance, in many countries in Europe, they have very good indicators in terms of access and in terms of equity and in terms of the reduction in financial exposure for paying for healthcare, otherwise known as financial hardship. So they have good indicators, but they didn't do too well with COVID-19. Part of that is related to the way that houses are constructed, in the sense that there's multi-generations living in the same house, grandmother, grandfather, nuclear family, and kids, and it spread in particular in southern parts of Europe. Others, and these are systems that are fairly well established and they're known to be good. They have universal coverage, pretty good access, and essentially are tax funded, and they're good quality. So it isn't necessarily related to that, but it is in a way. And that is the trust that people have, populations have in government and acting on their behalf. Therefore, their willingness to follow quarantine measures, mask wearing, vaccination, other public health interventions that we refer to as non-pharmaceutical interventions is higher in countries where there's trust in government. And a key component of having trust in government is the provision of national health care, provision of not necessarily that the government has to provide it, but the government actually guarantees it. So there's a level of trust that was already inbuilt. This level of trust is even furthered in certain parts of the world because of cultural differences and cultural perceptions, in the sense that in many parts in Asia, it is more of a collective mentality rather than an individual mentality. So in terms of reducing the effects of the pandemic or reducing the pandemic itself, a collective approach is often thought to be much more productive than an individual approach. It's more of a, Tim had alluded to this, a population-based approach. Again, people chomp at the bit. They don't like that. If they look at government as being intrusive and they look at government as being something that is not part of their lives. And that is, we're increasingly saying that that is an important part of the response. was the trust in government. And the third component, which is important and which I'd like to mention, is a lot of countries throughout the world are broke. They just don't have the money, for the extra expenditures associated with COVID-19 control. Many countries in the world have suffered reductions in their per capita GDP of over 10%. This is unheard of. This dwarfs the 2008 subprime mortgage ignited financial meltdown. This dwarfs anything we've seen in 100 years. And so for these countries, they have had very difficult time in terms of funding the COVID response. And that's related to the reduction in business activity because of the public health measures put into place. Many countries had enough fiscal reserves, or they've had to take loans, or had to turn to the international community to assist. So in some, it's a lot of different pieces, but one is the ability for countries to mount a response, and that was related to money. The second is the trust in government that the populations have. And the third is probably related to historical patterns of whether you had an epidemic flow through your region before. That's the third one. And the fourth one is some collective versus individual perceptions of you and your view, in society. Over.
Thank you. I think there's a little bit of irony when we say that we're an interconnected world, and that the decisions that we make have an impact on the economy and so forth, especially in a moment of a global pandemic. While if we are so interconnected, and I think that one of our guests in the audience has asked a question, I think David Gallagher asked a question, do we think the pandemic has helped us better coordinate internationally? I'd be curious to hear your thoughts on that, because, you mentioned that there was the bird flu and there was SARS and there was Ebola, and we had a poll about that. The number of individuals who died from Ebola, and the number of individuals who died from SARS, were much lower, and it seems that and so those pandemics were contained regionally. This did not happen, perhaps because of travel patterns, because of not recognizing it soon enough. But there were so many different messages that were sent. Some countries said, no, there's no need to wear the mask. Others said, and one of the reasons was because there were no masks available. This happened in France, for example. So I'm just really curious, we talk about interconnectedness, but at what level you're thinking about the financial market and the approaches and so forth. But what are we missing that didn't allow us to think collectively, aside from a governmental voice? What have we learned, and how can we improve the way that we react to a global pandemic in the future? Have you given that some thought? I know that Dell Med has been instrumental. We've had researchers like Jason McClellan who've accelerated the development of multiple vaccines that have proved effective in protecting millions of people and reducing hospitalizations. And we have been so fortunate at UT that we were one of the first hubs of distribution of the vaccine. And I think Austin, in comparison to the rest of Texas, was very fortunate in terms of this collective consciousness of saying we need to follow these certain protocols. But I'm really curious to hear from both of you how Dell Med, UT Health Austin, and the UT Austin community at large have played a role in addressing COVID-19. So that's at the macro level, but really more broadly, there is a little bit of a cognitive dissonance. Here we are interconnected, yet we haven't necessarily received the message. So I'm just curious if you have any thoughts on that.
Tim?
That's a great question. And you're right. I'm not sure I have all the right answers or the perfect answer, because I'm still sort of grappling and thinking about this myself, that there is this paradox or dissonance, and we all sort of recognize now that we live in this globally interconnected, society, and people move and commerce moves, and so many things sort of break down these borders. Yet when it comes down to decision making, for example, like I was saying earlier, we tend to sort of withdraw and retreat, and some of that is certainly political will. Some of that is, at least here, I think, as Peter was alluding to, the sort of individualistic versus collectivist mindset. And even though scaling up vaccination in India before Delta hit us may have served us better, again, there's that cognitive dissonance. What are the local policies? What is the very sort of local parochial strategies that we need to do? So, I don't think there's one thing that's going to change that. I mean, one of the things we're doing here at UT, Texas Global and Dell Med is from a sort of grassroots level, is starting with our learners to in classroom fora and instructional settings to engage in these sort of conversations and discuss these concepts. And then from an experiential standpoint, to expose our learners and create experiences where our learners can live, work in other settings in other countries. And so, for us at the Dell Medical School, our program in Kenya and in Mexico, and obviously UT has a broad range of international exchange programs. And I think those are so fundamentally important to addressing what you're getting at, Sonia. And I do think we have to sort of take that generational view that it's a long game. And but one of my favorite quotes is, as Mark Twain once said, I'm not going to get it right, but we're not going to sort of combat bigotry and racism and discrimination by sitting in our own little corner of the world. And we've got to get out beyond ourselves and our borders and experience the way other systems do things, other cultures, et cetera. And I think as an academic and as a faculty member at an academic institution, we got to believe that that's a core strategy to addressing that dissonance that's killing us right now in this pandemic.
Thank you. Well, Tim, now that I have you, I can't help but ask you questions at sort of the macro global health level for UT Austin. It's going to be very interesting for our audience to find out what UT Austin is doing in the realm of global health. And you work closely with our team here at Texas Global, and we're forever grateful that we have this collaboration across the institution, but also with you and with Dell Med. And you've done so for many years. And I was wondering if you could tell us a little bit about the genesis and the goals of the global health program at UT Austin, because it is so, connected to issues like the one we're discussing today, such as the global pandemic. Can you tell us a little bit about the genesis of the program at UT Austin, and then we'll ask Peter about how we can contribute to the global health conversation moving forward. How can UT do that? What is the vision for the future, and what does UT have to offer? So I'm really eager to hear both of you on those points.
Sure. Yeah, we're thrilled to at the medical school to be partnering with Texas Global and be part of the main campus community. We're the new kids on the block down in the corner of the 40 acres, so we have a lot to learn from the other 39, and excited to partner with students and scholars from across the university. So there's many ways to engage in, approach sort of global health. And Peter is working at one level, at the level of the WHO and economics and policy, and we're working at another level through the lens of the university and what can academia sort of bring to the table. And to share a bit of history, we are part of a global consortium and an academic global health partnership model called AMPATH, the academic model providing access to healthcare, which I alluded to at the beginning, is led by Indiana University, but now a consortium of 14 other North American and European universities, of which Dell Med is one, collaborating with a medical school in the Ministry of Health in Western Kenya. And they've been at this 30 years and really have taken the stance that it's long-term, longitudinal, committed partnerships built on equity, built without an end game in mind, built on the notion, the very sort of simple but practical notion that we're better together, and we can improve health and solve challenges together. And so that partnership in Western Kenya, I mean, I could go on and on about it, by essentially all markers has been one of the most successful academic global health partnerships in history, collaborating, working with over 500 Kenyan Ministry of Health clinical sites, an HIV/AIDS treatment and prevention program that has upwards of 200,000 people on antiretroviral therapy, one of the largest HIV/AIDS treatment and prevention programs in all of sub-Saharan Africa, continually funded by the PEPFAR, the President's Emergency Plan for AIDS Relief, put in place by the Bush administration. It has since expanded well beyond HIV to address chronic disease, cancer, mental health, maternal child health, et cetera. From a research standpoint, $180 million, I think at this point, in extramural funding, most of which has come from the National Institutes of Health, approaching 1,000 peer-reviewed publications, several thousand students exchanged over the years. And lives changed and ultimately health outcomes improved across the country, in addition to economic benefits and workforce generation, training, capacity building, infrastructure building, et cetera. And so that's what we're up to here, of being a part of that, but then replicating those concepts and that model of how universities can engage and commit to long-term partnerships and work across the mission of care delivery, research, and education, but leading with care and leading with this notion that it's the health of the population that's the primary concern. And following that, we can do good research and train our students, but all in service of improving the health of shared populations. And I think that's novel and unique for universities and academic medical centers. We know how to do research. That's our wheelhouse. We know how to train students and educate. And yes, we deliver care in our hospitals, but this notion that universities can really roll up their sleeves and engage in the business of health improvement and care delivery and capacity building. And that really unlocks this inherent power and untapped potential within university systems to do good. And so we are embarking on that partnership with our colleagues in Mexico, many of which have joined today, and delighted to see you here. And I think the last point I'll make is the other power that a university brings, as I alluded to, global health and in improving the health of the globe and addressing everything that needs to be addressed cannot be done by doctors or health professionals alone. It truly will take an interdisciplinary, multi-sectoral approach. And who better than a university with all that inherent power and all that intellectual capital and expertise housed within its walls, or its 40 acres in our case, lawyers and engineers and economists and anthropologists, and the list goes on. Who better to truly solve global health challenges? And I think in the history of global health, we've sort of paid that a bit of lip service. Oh yes, we really need this interdisciplinary, multi-sector approach in global health. But we haven't done a good job of really putting that into action. And I think that's where we really need to go. And that's one space in which universities can really play a major role, worldwide.
Thank you, Peter.
That's a fantastic question. And I was sitting and trying to think about a response, and here's something that here's a good example. This is my COVID-19 vaccination sheet for the National Health Service in the United Kingdom, where I was vaccinated. This allows me to travel. This allows me, because you see the code. This is what I got, from the National Health Service. I would be familiar. What is this? This is someone's handwriting on a piece of paper. This is not verifiable. This is useless. This is useful, but there's no global standard for this. And there's no, for instance, because the United Kingdom left Brexit, because of Brexit, its way of reporting the vaccination was not accepted by the European Union nor what's called the Schengen community. It was only recently, after a lot of the computer systems started to talk to each other through HIT or whatever the mechanism was, that they had the ability to do that. Is this global health? It absolutely is global health. And this requires a technical solution. There are other technical solutions that in the last 20 or 30 years, we've seen some fantastic progress, including the design and development and manufacture of COVID-19 vaccination in under a year. Groundbreaking, absolutely groundbreaking from the University of Texas point of view, as well as to others that were involved in this process at Oxford and other academic locale. Absolutely groundbreaking. But something that the fundamentals, which Tim had mentioned earlier, behind health, and that is around equity, around access, and around not having to go into poverty to pay for healthcare. These are fundamentals, and these have been around a long time, and we know that this works. We know that countries that do implement healthcare programs along these lines have faster economic growth. They have better outcomes. Good examples are Costa Rica, Sri Lanka, Singapore. It's very well established in the literature. But what we don't know is we don't know at the speed at which you can get that. And that speed at which you can get that is helped by technology. And it's helped by, many different sectors, which Tim had alluded to, getting involved in the struggle. We tended to be health specific, thinking that it was a matter of dispensing pills, doing injections, making the right diagnosis, or your standard public health measures. It's actually not that anymore. It is, we need to have the ability, for example, to monitor blood glucose for hemoglobin A1C, which measures blood glucose over the last 3 weeks. We need to have that available at primary healthcare sites. We need to have at primary healthcare sites where countries are impoverished, the ability to order HIV drugs and have them delivered. It's not crazy that they're going to be delivered by drone. This is here. It's not coming, it's here. And this kind of jump starting primary healthcare through the interface with a technical solution is something that places like the University of Texas squarely should be involved in, not only among academics, but among alumni, among business people, is that creativity in order to find a solution, which the University of Texas should put on the tower, because that's what we're about. We're about being creative, about finding a solution, and also doing it in strong consort with the private sector. And that's something that needs to be harnessed, because that can advance the basic foundation of primary healthcare and of equitable access and of good quality. And it can jumpstart it. An analogy is when I used to live in Africa, there were no mobile phones for the longest time, and it took forever to make a phone call. Ooh, talking about an hour and a half, couple of hours. And this was a phone call domestically, and when we lived in Uganda. Mobile phones came. You would see people, the first thing that started to happen with mobile phones were farmers started to get commodity prices so they were beginning to cut out the middlemen. There was mobile banking. There's reminders now that you need to come in for your HIV appointment. All sorts of things have happened, and from a simple phone. These are not smartphones, et cetera. These are the early versions. That kind of technology and that kind of approach has changed a lot of what happens in Africa, and it's especially through banking. And you could see this in health. It's beginning to happen, and I think that's an area that, as an alumni, that we should seriously sit and try and progress further, because that's definitely in our wheelhouse as an institution. And not just technology, but just bringing that different approach into more solution-oriented and using technology, using engineering, using governance, using law to push forward, the fundamentals of everybody gets a fair shot at healthcare and they don't have to be impoverished for it. Because we know those fundamentals equal poverty reduction. So how do we get that to move at a faster pace? And I think that the University of Texas should definitely consider increasing its exposure to that, not only for the purposes of the University of Texas, but for the struggle more generally in trying to get people better healthcare and therefore less exposed to poverty. Over.
And I would just, it's so true, Peter. It's such a good line of thought and set of points. And just to even take further your notion that, it's not all health is not all health care. There's actually now quite robust data that says it's about, 20% of what I do in the clinic and hospital matters, people's, morbidity and mortality can only be sort of accounted for by about 20% of what happens in clinics and hospitals. The other 80%, about 40% comes from health behaviors, smoking, physical activity, nutrition, those kind of things. And another 30% from even broader sets of forces, structural factors, politics, policies, cultural factors, et cetera. So not only do we need these, sort of innovative technological solutions that are sort of one step beyond healthcare delivery, but still interface with it, we need to go even another rung out, and tackle things that may seem to have nothing to do with health altogether, but actually matter a great deal to health outcomes. And this is where we start to approach strategies that, will impact climate change. So thinking about, there's data that says, tree density and cover in cities really matters to people's mental health and chronic lung disease and cardiovascular disease, et cetera. Food systems and food policy will affect, downstream affect diabetes and chronic disease. And if we can do these, larger interventions that both improve health and address poverty and socioeconomic inequities, then we can really move the needle on this.
I have to say that one of the difficulties of the Texas Global Dialogues is that the discussions are always so fascinating, and one wants to continue having the conversations. I think your points are really right on in terms of how the University of Texas at Austin can contribute to advancing global health and disparities, as well as increase of technology, combining technology with the work that we're doing, with the work that needs to be done in global health. And one of the things I'm thinking of is artificial intelligence and the role of artificial intelligence in supporting global health endeavors, whether it is, as you just noted, Peter, the use of the QR code, which is really rampant all over Europe and even in Asia, as a means to demonstrate that you are vaccinated and things of the sort, whereas that is not something that has necessarily been used globally, and that is creating these inequalities in terms of information transfer and so forth. So I think that now that we've also heard from Tim, there's so much to be hopeful and grateful for in terms of the work that's being done by our researchers, but also the practical work, as you said, Tim, that is taking place in Kenya, but that is also going to be taking place in Mexico. We are incredibly, I think, grateful for the collaboration that is starting with the Benemérita Universidad de las Américas in Puebla, and with the conversations and the work that is going to be taking place throughout Mexico and the region. So I think your work is going to be really, and the consortium and the work that's taken place in Kenya has been recognized really all over the world. So it seems to me that we still have a lot to work on, and your vision, Tim, of a global health institute at UT Austin is not just going to be a vision. I'm completely convinced that it will be a reality with your leadership and with the leadership of Dell Med. So it's very exciting. And now I really would like to thank you both. The fact that both of you are here today is representative of the connectivity between our alumni and our faculty and our leaders here at UT Austin. And it's a really wonderful experience to have you both exchange ideas and inform us from your different perspectives and worldviews and so forth, and to discuss this with our audience. And we would be remiss not to ask our audience to submit questions so that you could answer them. I know that we have a few questions here in the Q&A section at the bottom of the screen. So if you have more questions, please feel free to add them. But I think the first question from one of our esteemed alumnus is Erwin Mueller, asks something that's really important. Should health services be a right or a benefit? What are your thoughts on that?
Well, I'm squarely in the health is a human right camp, no question, and I just think that's fundamentally true from a moral perspective, from an economic standpoint, which I'm sure Peter can speak to. My generation in global health was largely inspired by Paul Farmer, who I'm sure many of you know from Harvard, still very active, started Partners in Health, featured in the book Mountains Beyond Mountains by Tracy Kidder. And, as brilliant and intellectual as Paul Farmer is, he coined this term stupid deaths. And I think a lot of us in global health are in it because we can't tolerate any more stupid deaths. And it starts with a premise that, first of all, a human being who lives next door to me has the same value as a human being born in Kenya or Mexico or anywhere in the world. And if we believe that to be true, then it's morally intolerable that some children die before their 5th birthday of a treatable disease like malaria. Or I think one of the stories he describes is the woman in rural Haiti who died in a car accident, bringing her mangoes to market. And it's not that she died in a car accident, that could happen anywhere, but what are the economic forces and road conditions and socioeconomic conditions that required her to be on this overpacked car early in the morning to bring her mangoes to market, and why did she have to die, and what services were lacking, and why, when I practiced in Kenya, why were women presenting with stage 4 breast cancer and on their deathbed when they didn't have access to mammograms and early screening and treatment, and the list goes on. And those are all stupid deaths that are preventable and that disproportionately happen in poor countries and to people living in poverty or minorities, etc. And health is a human right, and we can't tolerate that anymore. And we have to work to build systems and educate our students and learners that is also intolerable, and that we have to get up each morning to address that. So that's my answer to that question.
Tim, I such little to add to that excellent explanation, whether it's a right or a benefit. I take and I've heard this debate. It's an excellent question, and one which is posed very often. Here at WHO, it's a right. There's no doubt about it, and this is formed from many different angles. Some of the ethical angles that Tim had mentioned, and but some of the more concrete arguments that, for example, if I were to present this to the Ministry of Finance, whether it being a right or a benefit, has to do with the actual what happens when it's a right versus a benefit. And that is, I'll take the case of COVID-19. When it's a benefit, I'm assuming when it's a benefit, it's either you're paying for it through private health insurance or your employer's paying for it, or a portion of that, and that inherent within being a benefit as opposed to a right. And when it comes that way, especially with COVID-19, there was what we call a lot of churn in the market. And what happened was people lost their benefits. COVID-19, they lost their jobs, they lost their benefits. And what happened is that either they lose them or they have to start be another category, whether indigent or subsidized, et cetera. all of that churn, which is in some insurance markets, which is up to 25% of the insurance market, are administrative expenditures, just in changing somebody's status as a beneficiary. And that happened not because of anybody in particular, that happened because of COVID-19 and the reduction in employment. So right there, just from a common sense point of view, you start to look and you're like, why are we burning, this money for administrative expenditures associated with people changing their plans when it could be used on direct health care? That just is befuddling. Again, that's a different kind of argument. That's what I spend a good part of my day doing, is speaking to ministries of finance along those lines. Not whether it's a human right or whether it's a benefit, but if it is a benefit, this is what happens in terms of the use of these monies. And they're not used efficiently. They're wasted in a way because they're spent on changing someone's status. And when someone's status changes, what happens if they fall sick during that change in their status? So that's I tend to look at it from there's our standard response from WHO, but also there's I believe a more nuanced response, and that is just makes economic sense to get value for what you're paying as a benefit, to make it more of a right. And remember, if it's a right, it still can be implemented through insurance mechanisms. That's different. A right is the government is basically saying everybody's covered in one form or another. And it is basically saying, we will, help to design the system. It could be with private, it could be with public, but it's essentially saying it's trying to keep administrative costs low. So you don't have all these multiple plans, thousands and thousands of plans. You have one or two plans, but it can be delivered through many different ways. The fundamental is it's a right. Everybody has the benefits of using it. And then, it gets a bit tricky in certain places because whose right is it? Is it the right of the person born in that country, or what if they're there illegally? What if they're there in transit? What if it gets some interesting dilemmas, but generally speaking, it's just more cost effective as a human right and its universality. Over.
Thank you for these inspiring responses. And I think most of us here in the audience would agree that it is a right. But I'm looking at a question from Claudia Sanchez Bajo, which somewhat connects to this. And she's asking, how do you see the future of global health and the role of the World Health Organization versus other institutional responses such as the G20?
I think that's yours, Peter.
My apologies. Sonia, someone just came in and was open and shut the door despite my note. Do you mind repeating the question?
No worries. I think, establishing the premise that health is a right. What is the future of global health and the role of the World Health Organization versus other institutional responses that we've witnessed, such as the G20 response?
Mm-hmm. That's fantastic. And I think one thing that in general, the COVID-19, for example, vaccination, testing, covered more people than did, the access to that in general was better than, say, for example, impoverished people having access to what we call, essential care or day-to-day care. In other words, access to vaccination or personal protective equipment or messaging, et cetera, was a bit better in terms of equity and access than it was with more traditional services. And I think there's a lot to learn from that. and to see what is it that enabled that to happen and what were the benefits of that versus countries which just said, you still have to pay. You have to pay for vaccination. And I know that it's just befuddling that you would have an individual pay for vaccination, but it happens every single day. And people profiting off of something which essentially is helping economies recover, and it helps that facility make more money in the future as the economy recovers. It's absolutely befuddling. But that sorts of lessons learned about the expansion of coverage to non-traditional sectors, to elderly who didn't have coverage, to the impoverished, to others, we've learned a lot, and we learned a lot about the benefits of it and also some of the drawbacks. It's not all been a rosy picture. So I think that we're trying to learn in that what differed in terms of the COVID response, and how can we take these lessons learned, whether it be something as simple as electronic appointment systems, which never, or telehealth, that was unheard of in most countries, and now it's common practice. For example, in many countries in the Pacific, there's no doctor going there. Ships have stopped, airplanes have stopped. So people got creative, in terms of appointment systems. They get creative in terms of, providing online care. What can we take from all of that and push that forward post-COVID in terms of, bettering health more generally for the world's population? And this is a gold mine of what has happened. And this can happen in terms of something as simple as hiring contract workers, or engaging with the private sector, or using more telemedicine, or using different supply chains for COVID-19 vaccination. What did we learn from all of that, and start to synthesize that and say, hey, we learned this. It doesn't need to stop. This was a good lesson. So we could help in terms of pushing forward what we call universal health coverage further and faster by learning from COVID-19. What do we do differently? And a lot of it is around applying more technology. We've learned that very rapidly. And again, poor countries don't necessarily have bad technology. Oftentimes, I've been in many countries where the mobile phone coverage is hugely better than it would be in a developed country, and its use and its application. So that's just a whole nother area. And I think that we're trying to get our heads around is that the use of technology, as well as the lessons learned in COVID-19 and the response, and how applicable are they for the future? Because not all of them are applicable. Some of them are, short-term measures. A lot of them are measures which we should look at implementing long-term. Over.
Thank you so much to both of you for sharing your expertise and your vision, for helping us think more about how we can engage UT Austin more broadly in the field of global health and connect with the World Health Organization. Sadly, we aren't able to answer all of the questions that were shared with us this afternoon, morning, or evening. We have to draw the Texas Global Dialogues to a close now. And we're really grateful to our panelists and to all of you who joined us today. It was an engaging conversation. I hope you feel the same way I did. To our alumni with us today, we are looking forward to sending you an email if you're a registered participant, with a recording of the event and a brief survey. We actually would love to hear from you, and we'd like to know more about the topics that would be of interest for future events. Also, please don't forget to join the Texas Global Group in Hooked In. This is an exclusive online networking community for UT alumni, and follow us on social media to learn about these and other events hosted by Texas Global and the Texas X's. I want to thank you for attending, and I wish you a wonderful rest of your day or evening, safe and a happy holiday season. And I hope that we will meet in person in the near future. Again, really much gratitude to Chuck Harris, to Dr. Tim Mercer, and Dr. Peter Cowley. Thank you so much, and we will see you again. Thank you.
Pleasure. Hook 'em.
Welcome.
Sonia. Thank you.
Hook
Everyone.
'em.
Welcome.